So we're going to start with endocrine system. Okay, now before we go to the endocrine system, I first want to talk about just the hormones. Now, in your exam, they expect you to know the basics. They're not going to go in depth of each and every hormone, but if you know the basics, you know what is happening. Okay, so we're going to start with the base of the hormone. Again, other systems, it's going to be a little fast paced, but it's more memorization. So don't try and memorize in my lecture. Just try and listen to me, and then you're going to understand everything that we talk about. Okay, so we're going to start with the in your body. What is the system that's going to regulate everything? Like what in your body regulates homeostasis and everything? It is your hypothalamus. Your hypothalamus is something that's going to regulate everything. It's going to make sure there is homeostasis. So even with endocrine, you have the hypothalamus. Okay, this hypothalamus regulates your pituitary gland. Okay, it regulates the pituitary gland. It mainly is the one that stimulates the pituitary gland. I'm not really going over hyper. I'm telling you what happens in the body first. Okay, so it stimulates the pituitary gland. Your pituitary has anterior pituitary, and your pituitary is going to have your posterior pituitary. So you have your anterior pituitary and you have your posterior pituitary. Now, what are the hormones that are secreted by the anterior pituitary? So the hypothalamus goes and stimulates the pituitary to do its job. Now, what are the hormones secreted by the anterior pituitary? You have your ACTH. Good. What is the ACTH? Adrenocorticotropic hormone. Now, what does the adrenocorticotropic hormone do? Adrenocorticotropic hormone goes and stimulates the adrenal glands, right? So it's like a process. Hypothalamus stimulates the pituitary. Pituitary releases the ACTH, and your ACTH goes and stimulates the adrenal cortex to release what? So what does the adrenal cortex release? The adrenal cortex release cortisol. Yes, it's called cortisol is also called as a glucocorticoid, and it also secretes the aldosterone. So it's like glucocorticoid and the mineralocorticoid. So your aldosterone is going to be your mineralocorticoid. So this is what the ACTH does. Then you have your TSH. What does the TSH do? TSH is the thyroid stimulating hormone. So what gland is it going to stimulate? It's going to go and stimulate the thyroid gland to secrete the T3 and the T4, right? Then which is the other one? Then you have your FSH and your LH. What is FSH and LH? Follicle stimulating hormone and the luteinizing hormone. What does this do? This goes and stimulates the ovaries. Yes, your ovaries to release the estrogen progesterone, and it goes and stimulates the testes to secrete aldosterone. Yes, gonadotropins. Perfect. Yeah. So that's your gonadotropins, your FSH and your LH. They basically help in the stimulation of your ovaries and your testes to release estrogen, progesterone, and your aldosterone. Your growth hormone. Your growth hormone is also released by the anterior pituitary, and it helps with your growth. Okay. Then you have your prolactin. What is prolactin? Prolactin is a hormone that is secreted again by the anterior pituitary that is essential for milk production in pregnant women. So milk production in the breast is important. So that this is the one in pregnant women that helps in secreting the milk production. So here we did your hypothalamus goes and stimulates the pituitary gland. The pituitary has anterior pituitary, posterior pituitary, and your anterior pituitary has your ACTH, which stimulates the adrenal cortex. It has your TSH that stimulates the thyroid gland. It has your FSH and LH that stimulates the ovaries and testes. Your growth hormone helps with the growth, and your prolactin helps in the secretion of milk, or basically it helps in the production of milk during pregnancy. Everyone understood anterior pituitary? Now you have your posterior pituitary. Your posterior pituitary has two. Which are the two ones with your posterior pituitary? It has your ADH, also called as vasopressin. Okay, ADH is also called as vasopressin. Okay, and that's your anti-diuretic hormone, and it has your oxytocin. So you have your oxytocin and your ADH, that is your vasopressin. So anti-diuretic hormone. So what does the anti-diuretic do? That means it's not going to allow diuresis. So what is it going to do? It's going to basically, it's not going to allow diuresis. I mean, that means it's not going to help with retaining water, right? So your it's not going to help with losing out all the water. So what is it going to do? It's going to help in your retaining water. So it's going to prevent the dehydration. That's your anti-diuretic hormone, does not allow to lose all the water, and it's going to help in the retention of water. And what does oxytocin do? Oxytocin is a hormone that helps with the contractions. So during basically uterine contractions during labor, it basically, if they want to induce contraction, they could give oxytocin that is going to help with the uterine contractions during labor. Then also the milk production, not production, production is prolactin, but the ejection of the milk, you require contraction for the ejection of the milk, and that's when you need your oxytocin. Okay, everyone clear about the hormones in your body? Like who regulates anterior, posterior pituitary? Perfect. Now let's go to some let's go to something like that's how you're going to understand the deficiencies. Okay, first thing we're going to start is adrenal gland. But before we start adrenal gland, I want you guys to remember the function of the hormone, because if you know the function of that particular hormone, doing the differential diagnosis is going to get very easy. Okay, so we all know adrenal cortex is going to secrete your cortisol. Now, what does your cortisol do? Cortisol is something that helps in the glucose production. Okay, cortisol helps in the glucose production. So it helps in the gluconeogenesis, the whole thing that is there, and helps in your blood glucose. So it maintains basically the blood glucose levels. So blood glucose levels are going to be maintained by cortisol. It also regulates your blood pressure. So blood glucose levels and your blood pressure is going to be by your cortisol. Okay. Now your aldosterone. Okay. Yes, it also decreases inflammation. That is correct, Hiral. So your cortisol also decreases inflammation. Good. So it has an anti-inflammatory effect. What else? It also decreases the immune system. Okay. So it also decreases your immunity. So it decreases the immune system. So the glucose production, BP regulation, decrease the inflammation, decrease your immunity. Now, what does the aldosterone do? Aldosterone is the drug. If you know, it's a hormone, and you have drugs also that do the same thing, like which use aldosterone. What does it do? It basically it retains potassium. It's basically what does it do? It's going to throw out. It's going to retain your sodium and water, and it's going to throw out your potassium. Okay, so it's basically retaining your sodium and your water, and it's going to throw out potassium. So it eliminates your K, and it keeps in sodium and water. Similar to your angiotensin 2. Remember what your angiotensin 2 used to do? That it retains sodium and water and it throws out potassium. Same thing, it is going to retain sodium and water and it's going to throw out potassium. So these are your function of your cortisol and aldosterone. Why did we do this? Because when we are going to do Cushing's and Addison's, this is going to be very helpful to remember the signs and symptoms. So remember, cortisol is essential for the glucose regulation, BP regulation. It also helps in decreasing the inflammation. It also decreases the immune system. Whereas your aldosterone is going to just help with your BP mechanism. Okay, everyone clear? Now let's do the difference. Now let's do the main difference. Okay, now when we have Addison's and Cushing's, okay, so I'm going to put it here. Okay, you have two main disorders when it comes to the adrenal cortex. One is your Addison and one is your Cushing's. What is Addison's? What is Addison? Addison's is your decrease in your cortisol. It's your decrease in your cortisol and aldosterone. So it's your decrease in your cortisol and aldosterone. Why? Because of adrenal insufficiency. That means your adrenal gland is not producing cortisol and aldosterone. Mainly your adrenal gland is not working properly. So if it's not working, it's not going to be able to secrete the hormones that it does, right? So that is your adrenal insufficiency. And with Cushing's, what happens? Cushing's, it is over. Like it's over secretion. Okay, everything is elevated. It is over secretion. Your Cushing's has your over secretion of your cortisol and your aldosterone. So Addison's is adrenal insufficiency. What would be the reasons for having Addison's? Like, what is the reasons for having your adrenal insufficiency? What is the reason for having adrenal insufficiency? Maybe your tumor, right? You could have like an infection, or you could have an autoimmune problem. right? Autoimmune, you could have an infection, or you could have atrophy of the adrenal gland, right? Atrophy of the adrenal gland, you could have tumor of the adrenal gland. Anything can lead to adrenal insufficiency. Now, how do I remember Addison's disease? Very simple. We always make up stories. So Addison's, think about a brown lady, a brown girl, or a brown woman, okay, a brown woman who's really thin, weak, and petite. Okay, so think about those old ladies who walk with a stick, like really thin, fragile, weak, and brown in color, brown skin. Okay, like my skin color. Why did I say brown woman, thin and weak? It will help you remember the signs and symptoms. Now, first thing, let's look at, you know that if your adrenal insufficiency is there, your cortisol is going to be decreased as well as your aldosterone. So if the cortisol is reduced, what will happen to the blood glucose? Excellent. Your blood glucose is going to decrease. What will happen to the blood pressure if the cortisol is reduced? The blood pressure is also going to decrease. What will happen to your let's say, what will happen to a person like with the like if you're losing out all the water, like blood pressure is decreasing, if you're losing out all the water and the sodium, this person is going to get dehydrated, right? Dehydrated, and going to have hyponatremia, and it's retaining all the potassium. So what are you going to see? You're going to see hyperkalemia. So this much you guys are going to remember if you know the signs and if you know the function of the aldosterone cortisol. Can you remember this much without even thinking now? Blood glucose is going to decrease, blood pressure is going to decrease, there's going to be hyponatremia, there's going to be hyperkalemia, you're going to be dehydrated. Now you think about the lady who's brown. Why is it brown? Because of your brown. Why did I say brown? Because they have a bronze pigmented skin. Okay, bronze pigmented skin, and they have a bronze pigmented skin because of the melanin. So because of your melanin, increase in the melanocyte stimulating hormone, MSH, that increases. Okay, melanocyte stimulating hormone increases, which is why they have brown pigmented skin. Now, when I talk about a person who is really weak, fragile, thin, can I say thin? That means they're going to have anorexia. When I say weak, can I say generalized weakness? That is called as asthenia, right? Asthenia is going to be your generalized weakness. Okay. Correct. So it's going to be, yes, it's going to be fatigue, and it's going to be fatigue. It's going to be generalized weakness. There's going to be asthenia. Then yes, now if this old lady is there, like old fragile lady, will she be able to tolerate cold? She's not going to be able to tolerate cold. Excellent. So there is going to be no toleration of your cold. So there's going to be cold intolerance. What about stress? She's all, she's going to be like stress, intolerance to cold, intolerance to stress. There's going to be anxiety. There's going to be depression, anxiety, depression, anorexia, cold intolerance, stress, anxiety. All of this is going, and GI disturbances. Okay, GI disturbances. So all of this is something you're going to see in your Addison's disease. Okay. So again, going to repeat, we know the two hormones. We know cortisol and aldosterone, which is why we know blood glucose decreases. You know that your blood pressure is blood glucose decreases, blood pressure is going to decrease. You're going to lose all the water and the sodium. So hyponatremia, dehydration, increase in potassium. So hyperkalemia, increase in the melanocyte stimulating hormone causing bronze pigmented skin. Again, weak, thin, fatigue. So asthenia, anorexia, stress, anxiety, depression, cold intolerance, GI disturbances. So this is going to be your Addison's disease. Is it easy to remember? Will you forget Addison's disease? Yes, anorexia can cause loss of hair. That's correct. So will you forget Addison's disease? No, because we have this brown woman who's thin, who's weak, and who's petite. Okay. Now we are going to go to Cushing syndrome. Okay. Cushing syndrome is an overwork. So it's basically an over secretion of the corticosteroid. Now, how do I remember Cushing syndrome? It's like a white guy who's chubby, white big guy, chubby, white big chubby guy. Okay, why do I say that? Because he's white, so he's not going to be like so he's white, so his cheeks are going to appear very red. So we say that there is going to be like your reddish kind of color on your skin. That's also called as ruddy appearance. Okay, so we call it like a ruddy appearance on the face. That is why I mentioned white, big and chubby. Then big, so there's going to be a lot of centripetal obesity. What do I mean by centripetal obesity? Centripetal obesity is like your abdominal obesity. And then you're going to have a buffalo hump, like your kyphotic, centripetal obesity, buffalo hump, moon shaped face, because you're so bloated all the time. You're so bloated, so that is why there is like a moon-shaped face. So think about a big guy, okay? Moon-shaped face, buffalo hump, centripetal obesity, ruddy appearance, right? Now, exactly opposite to your Addison's. If your blood glucose is decreased in Addison, what happens to the blood glucose here? Your blood glucose is going to increase. Your blood pressure is going to increase. You're going to have more water retention. You're going to have more bloating. You're going to still have a lot of loss, like your electrolytes are not, you're going to have hypokalemia. Okay, you may not have hypernatremia. You may still continue having hyponatremia. Why? Because there's too much water. So the concentration of the sodium is not that much that you can call it hypernatremia. So yes, you can call it hypokalemia because of a lot of water. Okay, so then you're going to have instead of bronze, you have ruddy appearance. Okay, then instead of anorexia, you have bloating. Okay, and now think about what happens when you have too much corticosteroid in your body. Like if you take too much corticosteroid, if you take too many corticosteroid pills, what happens? Osteoporosis, increased blood glucose, increased blood pressure, weak bones, tendon rupture, muscle rupture, delayed wound healing, decreased immune system, right? So all your side effects of corticosteroids can also be a side effect, can also be seen as your Cushing's, right? Because same thing, you're taking too much corticosteroid in excess, and here you have too much cortisol hormone in excess. Same thing. So it's very easy to remember Cushing's disorder, right? Muscle atrophy, yes, correct. There's going to be muscle atrophy. There's going to be proximal muscle weakness, because when you take too much steroid, you're always going to have proximal muscle weakness, right? Whenever you're going to take steroid, you're always going to have your proximal muscle weakness. Okay. All right. Perfect. Next thing. So everyone clear now? Why do you get Cushing's disease or Cushing syndrome? Now, this is there are two things here. Okay, your Cushing's can also be called as a Cushing syndrome, or it can be called as a Cushing's disease. Okay, you can be called it as a Cushing syndrome, or you can call it as a Cushing's disease. Now, both of them are going to show your same signs and symptoms, whether it is Cushing syndrome or whether it is Cushing's disease. What is the difference? You call it a Cushing syndrome when the problem is in the adrenal gland. Okay, so you call it syndrome when the problem is in the adrenal gland. So maybe you have an adrenal tumor. Okay, maybe you have a adrenal tumor, so you can call it like your Cushing syndrome. But if you have a tumor that is in the pituitary gland, okay, so you know pituitary gland has a tumor, so there will be like maybe ACTH is less or anything. So basically it's affecting the ACTH. The ACTH is affecting your Cushing's. So when the problem is in the pituitary, that's when you're going to call it a Cushing's disease. When the problem is in the adrenal, you're going to call it a Cushing syndrome. But is there any difference in the signs and symptoms that you see? There's going to be no difference in the signs and symptoms. It's just that you call it Cushing syndrome when it's in the adrenal cortex, and when the problem is in the adrenal cortex, and you call it Cushing's disease when the problem is in the pituitary gland. Okay, everyone clear? Now, definitely medical management is something that is essential for both Addison's and for Cushing's. For your Addison's, you require like hormone replacement. Definitely they need to replace the hormone. But because this person is weak, good fluid intake, good calorie intake, like basically replenish the water, replenish the electrolytes, good calorie, good fluid intake. And for Cushing's, again, if it's a tumor, you got to make sure that there is surgery done and the tumor is relieved. Or if the Cushing syndrome is because of excessive of corticosteroid, then slow weaning of corticosteroid is going to be beneficial as a treatment for Cushing's. Okay, everyone good with Yes, that's correct. Okay, so they won't really ask you about the hyponatremia or hyponatremia and Cushing's, but if you have to see, there won't be hypernatremia for sure. It could be normal or it could be hypo because there's a lot of water inside. So you cannot really say hypernatremia because the concentration of water is not less, the concentration of electrolyte is not increasing. Okay, so that's why you can never call it hypernatremia. All right. Now, also they have like hirsutism and thinning of hair. Like Cushing's also have hirsutism. What is hirsutism? Hair, is it hair loss? No, it's excessive hair growth. Hirsutism is excessive hair growth. Okay. So thinning. So you have your hirsutism can be seen. Your thinning of hair can be seen. Even your menstrual cycles can be irregular when it comes to Cushing syndrome. Okay. So everyone clear what happens with the adrenal gland? What are the hormones and what are the two things? Good. Now we move on to the next one. The next one is going to be your thyroid. Okay. Now, like I said, this is not too difficult to remember. So no mind block that you don't remember these signs and symptoms. Like you see in the class, it's going to become easier to memorize these signs and symptoms. Okay. Let's start with your hypothyroidism and you have your hyperthyroidism. Again, we are going to make up stories to remember. Okay, what is hypothyroidism? Hypothyroidism is when there is a lack of your T3 and your T4 hormone. So your T3 and your T4 hormone is reduced. It is called as hypothyroidism. Now, why is the T3 and T4 reduced? It could be thyroid atrophy, or it could be like decreased activity of the thyroid gland because of thyroid gland atrophy, or it could be because your thyroid gland is removed, or it could be because of an autoimmune thyroid condition. What is the autoimmune thyroid condition called? An autoimmune thyroiditis is also called as your Hashimoto's disease. Good job. So that's your Hashimoto's disease. Okay, so you could have thyroid atrophy, autoimmune thyroiditis, Hashimoto's disease, removal of the thyroid gland. All of this could cause your hypothyroidism. Now, here I want you to remember a story that it is a lazy person, like a very lazy person, always sitting, always laying down on the couch. So lazy person laying on the couch, okay, laying on the couch, unhealthy. You could rather say lazy and unhealthy person, okay, laying on a couch all the time under a comforter. Okay, this is how I remember this. So you are someone who's really lazy, unhealthy, laying on the couch all the time. So based on this scenario, tell me if the person is really lazy, what is the metabolic activity going to be? Is it going to be decreased or is it going to be increased? Everything, all your metabolic activity is going to be decreased. So there's going to be a decrease in the metabolic activity. Okay, if you're lazy and you're laying on the couch all day, are you going to be hungry or you're not going to be hungry? You're not doing any work, so you're not going to be hungry. Your appetite is going to be decreased. If you're laying on the couch all day, your bowel movement is not really good. So bowel movement is not really good. What do? You get constipation. If you're laying on the couch all day, you're definitely going to have weight gain, right? Now, if you're lying down on a comforter like this, watching TV, what's going to happen to your muscles? Your muscles are going to get weak. So that's why we call it a proximal muscle weakness is typical. Okay, so you typically see your proximal muscle weakness. You're laying under a comforter. So what are you feeling? You're feeling cold. So there is cold intolerance, right? Now, if you are just think about somebody who's just laying and like lazing all day, what is going to be the heart rate? Decreased. And think about an unhealthy individual. What happens to the BP? BP increase. Now you will see this discrepancy in your therapy aids. Therapy aid will say BP is also decreased. That is incorrect. We follow Goodman and a lot of other researches. Also, if you look online, your PubMed and CBI, all of them have BP that is going to increase. Okay, so we stick to BP increased. Okay, so heart rate decrease, blood pressure increase, weight gain, constipation, appetite decrease, decreased metabolic activity, proximal muscle weakness. Of course, if you're not moving anything, what will happen to your joint? Your joint is going to get stiff. So you're going to have joint stiffness. What happens to the deep tendon reflexes? Your deep tendon reflexes are going to be delayed, or you can say prolonged. Okay, so there is a difference between prolonged and hyporeflexia. Hyporeflexia means the reflexes are diminished. Prolonged means they are more delayed. But most of the time, if you have an option which says delayed or prolonged reflexes, that's going to be correct. But let's say there is no other correct option, but there is an option for hyporeflexia, hypo, HYPO, hyporeflexia. You can pick that if no other option is suiting for your hypothyroidism. But if there is an option which says delayed and prolonged reflexes, that will be correct, right? If you are lazy, laying on the couch all the time, what happens to the sweating? Sweating is going to be decreased. Your nails are going to be brittle. So there's going to be dry hair, dry skin, and they're going to be brittle nails. Okay. And now, if the hypothyroidism is non, yes, ichthyosis, that's correct, Riddhi. Ichthyosis is the dryness of the skin. Okay, so yes, they are going to have dryness of the skin, which is ichthyosis. They have xeroderma, which is again your seen like that's dryness of the skin. Both of that can be seen with your hypothyroidism. Okay, now if you have hypothyroidism that is uncontrolled for a long period of time, then they are going to develop myxedema. What is myxedema? Myxedema is a condition which is like your swelling of the hands, swelling of the face, swelling of hands, face, feet, which can eventually lead to coma and death. Okay, so it can eventually lead to coma and death. Okay, that's going to be your myxedema. All right, everyone good? So far, everyone with me? Myxedema is your swelling of the face, swelling of the feet, swelling of your hands, feet, face that can eventually lead to coma and death. That's your myxedema that is seen with your hypothyroidism. So remember this story, lazy, unhealthy person laying on the couch all day under a comforter. Okay, I have some spelling errors here, but yeah, okay, laying on the couch. So what will happen? So myxedema, there'll be a lot of swelling of your feet and hand and face. So yes, Dolly, then it will become an emergency. If you have significant swelling, you see that, then it will be an emergency. Okay, so remember hypothyroidism is reduction in T3 and T4. It could be because of thyroid atrophy. It could be because of autoimmune thyroiditis, Hashimoto's disease. It's basically somebody who's lazy and unhealthy. So if you're lazy and healthy, laying on the couch, that means decreased metabolic activity, appetite decrease, constipation, weight gain, proximal muscle weakness, cold intolerance, heart rate decrease, blood pressure increase, dryness of the skin, hair, brittle nails, joint stiffness, delayed or prolonged reflexes, and myxedema. Okay. There are a couple of 2-3 more points, but I want to first cover hyperthyroidism before I go to those 2-3 points. Okay, so is this clear? Will you remember this now? Okay. Now, hyperthyroidism, you just have to think about opposite. You have to think about a very, very hyper person. Okay, hyper person who's running, very hyper person who's running all day. Okay, running around without resting at all. That is your hyperthyroidism. So what will happen to the metabolic activity here? Now, metabolic activity is going to increase. What will happen to the appetite? The appetite is going to increase. Instead of constipation, you have diarrhea. Instead of weight gain, you have weight loss. Instead of proximal muscle weakness, you can continue having muscle weakness, but there will be generalized muscle atrophy and generalized muscle fatigue. So there will be generalized muscle atrophy and generalized muscle fatigue. Okay, these people are cold intolerant. Hyper will become heat intolerance. Here the sweating is decreased. Here the sweating is going to be increased. Here you have dry skin and brittle nail. Here you have silky hair and hair loss. Okay, that's going to be silky hair. That's going to be hair loss. Okay. Deep tendon reflexes here are delayed and prolonged here, or it can be hyporeflexia. Here you have hyperreflexia. Okay. Here you have myxedema or swelling. What do you have here? There is something which is called as exophthalmos. What is exophthalmos? Exophthalmos is your bulging of your eye. Okay, exophthalmos is your bulging of the eye. You have the sockets that are the eye sockets are completely sunken inside. Okay, these eye sockets get sunken inside, and there is your bulging of the eyeballs. That is going to be seen with your exophthalmos. Okay, yes, facial flushing, restlessness. Now, in addition to all this, you may have restlessness. You may have restlessness. You may have palpitations, okay, restlessness, palpitation, tremors because you're really active. You have sleep disturbances because you cannot sleep. You're very, very active. Your mind is running. So restlessness, palpitation, tremors, this is going to be seen with your hyperthyroidism. Here you had your autoimmune thyroiditis and you had your Hashimoto's disease, right? What do we have here? This could be your Graves' disease, your thyrotoxicosis, that means toxic. Okay, thyrotoxicosis means excessive thyroid. Okay, thyrotoxicosis, or you can say thyroid storm. Okay, so you have your thyroid storm, thyroid toxicosis, Graves' disease. Okay, yes, you see generalized muscle weakness. Yes, you see fatigue. Basically, you see like too much fatigue in this person. You see muscle atrophy in these people. Okay, because they're really, really hyper. So thyroid storm, thyrotoxicosis, Graves' disease. All of this is going to be seen with your hyperthyroidism. Okay. Now, what is goiter? Goiter is different. Goiter is, why do you get goiter? Goiter is because of iodine. Goiter happens when you have deficiency of iodine. There is going to be an enlargement of the thyroid gland. That is different. But if you look at your textbook, some varied say that you could see goiter with hypothyroidism. Some say you could see goiter with hyperthyroidism, which is why, because of the discrepancies, they won't really ask. But in case they ask you, you will put goiter under hyperthyroidism, because I think Goodman says that it is under hyperthyroidism. So your goiter here is going to be under hyperthyroidism, but goiter has nothing to do with thyroid. Mainly, goiter is because of your iodine deficiency. Okay, which is why the salt that you eat, they have iodized salt so that you don't get your iodine deficiency. Okay, now the next thing is the same thing is your frozen shoulder. Frozen shoulder can be seen in both. It can be seen in hypothyroidism and hyperthyroidism. But which is the one which has more common, which is more common for frozen shoulder? Again, it's going to be your hyperthyroidism. Okay, so if you have to pick between hypo and hyper, then it will be hyperthyroidism for your frozen shoulder. Okay, now this was the main. There are two more signs and symptoms that I want to do, but before that, have you understood these? Are you clear with the signs and symptoms of hyper so far? Okay, now both of them, okay, are going to have something associated with the TSH. What was the TSH? TSH was your thyroid stimulating hormone, right? Your TSH. So what happens to the TSH levels in hypothyroidism? What happens to the TSH levels in hypothyroidism? Excellent. You all know it. It increases. Why does it increase? Because TSH is the thyroid stimulating hormone. That means your pituitary is telling is secreting the TSH and telling the thyroid that go secrete more T3 and T4. When you don't have any, like when you don't have any T3, T4 coming out of the thyroid, the pituitary the pituitary is going to feel like, let me secrete more TSH. Let me secrete more TSH so that the thyroid will do the job. Right? So the pituitary goes on secreting more and more TSH so that the thyroid can secrete more T3 and T4, which is why your TSH levels increase in your hypothyroidism and TSH decrease in your hyperthyroidism because you're secreting so much T3, T4. So the pituitary feels like enough job is being done by the thyroid. Let me reduce my TSH secretions. Okay. So Even though TSH is increased with hypothyroidism, your T3, T4 is low. Even though TSH is decreased with hyperthyroidism, your T3, T4 is high with your hyperthyroidism. Okay, is that clear? Now about osteoporosis. Think about it and tell me, who do you think has more increased chances of osteoporosis? Is it hyperthyroidism or hypothyroidism? Hyperthyroidism, very good. The calcium levels, okay, your calcium levels decreased in hyperthyroidism, so they have increased chances of osteoporosis. Again, your menstrual cycle, what happens to the menstrual cycle in hyperthyroidism? There would be amenorrhea. Think about very thin people, always restless. Think about your athlete's triad. Remember, do you guys know what is an athlete's triad? Yes, female athlete triad. What is a female athlete triad? Anorexia, osteoporosis. What is a female athlete triad? And amenorrhea. So it's going to be your anorexia, osteoporosis, and your amenorrhea. So that is why your calcium levels, in the blood, your calcium, you have more osteoporosis because in the blood the calcium levels get increased. Betul, but in your bone, your calcium levels are decreased, which is why you have more chances of osteoporosis. Same thing with your hypo, you have less chances of osteoporosis, okay? And you have heavy periods. So your menstrual cycle is more heavy, okay? But hyper, it's going to be more of amenorrhea. Okay, hypoparathyroidism, Dolly, we will be doing it. Don't associate thyroid with parathyroid. Both are completely separate glands. We will be doing those two. So both of them are going to have weakness, both of them are going to have exercise induced intolerance, both of them are going to have exercise induced fatigue, but hyper is going to be more of fatigue, like more of fatigue is hyper, and more of myalgia, that is muscle pain and weakness, more of myalgia is hypo, and more of fatigue is going to be hyper, if that helps. Okay, yes, your calcium levels in the blood increase, which is why in the bone it decreases and you get osteoporosis. Okay. Yes, both of them will have exercise intolerance. That's correct. The female athlete triad is anorexia. Your female athlete triad is anorexia, amenorrhea, and this is very important. You should know about the female athlete triad. Anorexia, amenorrhea, and your osteoporosis. Okay, young women, young females, when they present with anorexia, amenorrhea, and osteoporosis, that's your female athlete triad. Okay, what is the age group for the female athlete? Teenagers. Okay, that's the age group for your female athlete triad, young females. Okay. Yes, below 20, correct. Okay, now what does before going to parathyroid, what does the growth hormone do? What does your growth hormone do? Growth hormone, when it is increased, everything is going to grow a lot. So we call it your gigantism. Okay, with growth hormone, because everything is increased a lot, we call it gigantism. So what are the features that you will see? If somebody is a giant, what do you see? You see enlarged skull, you see enlarged feet, you see enlarged hand, you see enlarged jaw, right? Your enlarged jaw is called as prognathism. I don't know if you've heard this. Prognathism is a word for your enlarged jaw. Just put it down there so in case you see it anywhere, you know what it means. Increased height, increased skull, enlarged skull. Okay, then you have your enlarged feet. Everything increases. Your skin thickness increases. Your fat pad thickness increases. Everything becomes increased. So they have more chances of carpal tunnel syndrome. They have more chances of having plantar fasciitis. Everything, your enlargement of the lips, nose, tongue, cardiomyopathy, enlargement of your liver, myopathies, and thickened skin, sensory problems. So everything is enlarged. Every organ in your body. Every single organ in your body is going to be enlarged. That is going to be a gigantism. And what is dwarfism? Dwarfism is every single thing in your body is going to be decreased. Decreased height, less tiny nose, tiny eyes, tiny jaw, cardiac size is going to reduce, small fingers. Okay, that's going to be called as dwarfism. Priya, you mentioned acromegaly. Acromegaly is also when it is increased. So when it is increased, you could have either gigantism or you could have acromegaly. Right? Gigantism is when everything is increased, okay, and acromegaly is when you have everything is decreased. Okay, sorry, acromegaly is basically when your horizontal bones are increased in size, not your longer bones. Okay, so acromegaly is basically when everything horizontal, whatever bones in your body that are horizontal, they will be enlarged in size. That is acromegaly. But typically in your exam, they will just expect you to know, yes, your flat bones. They'll expect you to know gigantism, where everything is increased, the patient is bigger in size, and dwarfism. Okay, Betul, think about a dwarf. Okay, Snow White and the Seven Dwarfs, your story. That's when the dwarfs, how do the dwarfs look? The dwarfs look tiny, right? Okay, like if you watch Game of Thrones, then you have your tiny dwarf in there, right? So like that tiny person is called as a dwarf. Okay, so yes, you're Tyrion Lannister. So yeah, so if you've not watched it, okay, but a person, you might have seen short people, right? You might have seen people who are really short. They're called as dwarfs. So that is because of your lack of your growth hormone. Okay, everyone clear? Now let's move on to parathyroid. Okay, again, this is not going to be difficult to remember, so don't worry about it. So far, do you feel confident about your adrenal, your thyroid? Do you feel confident about it in remembering? Great. Okay. Is other systems really that bad? Don't be nice to me and say no. Be honest. All right. Okay. Hyperparathyroid. I really like it. So, okay. So, yes, your hypoparathyroid. Okay. Your hypoparathyroid is your reduction in your parathyroid hormone. So, what does the parathyroid regulate? Okay. What does the parathyroid regulate? The parathyroid regulates the calcium and the phosphate levels. Okay, we are going to only worry about the calcium to remember the signs and symptoms, but it basically regulates the calcium and the phosphate. So if you have hypoparathyroid, okay, if you have hypoparathyroid, that means your calcium is going to decrease and your phosphate is going to increase. Now, where is this increasing happening? Where is this decreasing happening? In the blood? In the serum, in the blood, or in the bones? In your serum, that's your blood. Okay, so this is happening in your blood. Okay, serum calcium, serum phosphate. Now, hyperparathyroidism means your calcium is increasing and your phosphate is decreasing. Okay, so your calcium increases and your phosphate decreases in the blood. That is your hyperparathyroidism. Okay, so let's start with hyperparathyroidism. I have a very interesting way of learning this. Okay, so you have a mnemonic which is going to be bones, stones, groans, moans, and sensory. Okay, this is how I'm going to remember it, and you are also going to remember it this way. So think about it. If the calcium is increased in your blood, that means calcium has to be taken out from the bones, right? If the calcium is increased in your blood, that means your calcium needs to be taken out from your bones, right? So what is happening to the bones? If your calcium is increasing in the blood, you're going to have osteoporosis, right? So osteoporosis, arthralgia, increased risk of fractures, deformities, gout. Can I say all of this is possible? So this will come under bones category. So if your calcium is increasing in your blood, that means your calcium is going to decrease in your bones. So you're going to have your arthralgia, you're going to have a risk of fractures, your osteoporosis, deformities, and gout. That's going to be coming under bones. Now the next one is, think about if you have a lot of calcium in the blood, what organ is it going to affect? Where does the stone go and deposit? In your kidney. So you have stones. That means you have kidney stones, you have renal insufficiency, right? So kidney stones, renal insufficiency, that can be seen with your stones. What is next? Groans. When you are like, when your tummy growling, right? That's groaning. Okay, so yes, you can have like constipation or peptic ulcers or pancreatitis, anything in the tummy. Okay, so peptic ulcers, pancreatitis, or your constipation, that means you are going to groan. Okay, so bones, stones, groans. When do you moan? Like after such a long day, at the end of the day, when you go to bed and you're really tired and you're really fatigued, you're going to be like you can moan, right? So basically, tired, fatigue, muscle weakness, anxiety, depression, all that can lead to moaning. Okay, so mainly when you're tired, fatigue, weakness, it's going to cause moaning. So bones, stones, groans, moans, and what comes under sensory? Okay, what comes under sensory? Sensory is going to be glove and stocking loss, right? Yes, Hira, definitely after this lecture. For me, I think the whole October month that happens. I mean, every exam month that happens. Okay, so that's going to be glove and stocking kind of distribution. So that's going to be having a glove and stocking kind of a distribution. All right, so hyperparathyroid is increased calcium, decreased phosphate. What do you need to remember? You need to remember bones, stones, groans, moans, and sensory. What is bones? Bones means increased risk of fracture, arthralgia, osteoporosis, deformities, gout. Stones, kidney stones, renal insufficiency. Groans, peptic ulcer, pancreatitis, you could have your constipation. Moans, fatigue or weakness or proximal muscle weakness or any muscle weakness, and depression sometimes that could lead to moaning. And sensory is going to be your glove and stocking kind of a distribution that's going to be seen in your sensory. Okay. Can we say glove and stocking? Yes. Glove and stocking is always distal to proximal. And even with hyperparathyroidism, your neuromuscular excitability, okay, your neuromuscular excitability is reduced. Okay, that means you're slow a little bit. Okay, so glove and stocking means yes, it's like a sensory loss, like polyneuropathy. You will have distal to proximal kind of affection. So yes, you're correct. Glove and stocking kind of a sensory distribution. Everyone clear with hyperparathyroidism? Why your calcium is increased, your phosphate is decreased, which is why you have bones, stones, groans, moans, and your sensory. Okay, I think I think there are images of these mnemonics in your LSP content folder if you look under images, so that you will be able to see that. Yes, now there is a sign. Okay, there is a sign called as a salt and pepper sign that you see with hyperparathyroidism. So this is called as a salt and pepper sign. Why salt and pepper sign? Let's say for a person with hyperparathyroidism, if we take an X-ray of the skull, if we take an X-ray of the skull, you will see when we take an X-ray of the skull, what do you see? You see that all the bone is getting absorbed. So instead of looking white, what is the bone going to appear? Gray. So some of the bone is going to appear gray, some of it white, some of it gray, some of it white, which is why we say it like a salt and pepper sign. So that's an X-ray of the skull. X-ray of your skull will show a salt and pepper sign because of the resorption of your trabecular bone. Okay, yes. Everyone clear with hyperparathyroidism? These are the same signs that you will see with hypercalcemia also. Okay, because increased calcium in the blood. Now, when you have decreased calcium, okay, what is the mnemonic that we are going to use for decreased calcium? We are going to use your mnemonic CATS. What is CATS? CATS means here, what is C? C is convulsions. A is arrhythmia. So you will have convulsions, you'll have arrhythmia, you'll have tetany, and you'll have stupor. Along with it, definitely muscle cramping, and that could be that your muscle cramping is going to be there. Okay, your muscle cramps, and then your fatigue and your increased. See, here your neuromuscular excitability is reduced. Here your neuromuscular excitability is going to increase. Okay. So this is your CATS. So always remember convulsions, arrhythmia, tetany, and stupor. Why do I specify in remembering these four? Because in the exam, they're very smart. They can give you tetany along with tachycardia. Which one will you pick? You will pick tetany. Okay, tetany is more like significant because if they write arrhythmia, then arrhythmia is correct. But if they put like, sometimes, they feel like, okay, tetany and TT, tetany or tachycardia. I want you all to remember tetany, okay? Convulsions, arrhythmia, tetany, stupor, okay? Along with increased neuromuscular irritability. Now, the two signs here, you have two signs here, okay? Like here you have your salt and pepper sign. The signs here are going to be two. One is going to be a chopstick sign. Okay, so one is going to be the chopstick sign. What is a chopstick sign? Chopstick sign is when you tap in front of your ear like this. When you tap in front of your ear, you're going to have tingling in that entire, like tingling in the entire facial nerve distribution everywhere, wherever the facial nerve supplies. So you'll have tingling in the distribution of the facial nerve. Okay, so that's going to be your chopstick sign. So when you tap in front of the ear, tingling in the entire distribution of the seventh cranial nerve, facial nerve, is called as your chopstick sign. Okay. And after your chopstick sign, you have your sign which is called as a Trugeau sign. What do we mean by Trugeau sign? Now, this Trugeau sign is related to your tetany. So when you inflate a BP cuff, okay, when a BP cuff is applied and a BP cuff is inflated, what will happen? The patient will go into a tetany. All the forearm muscles will go into a tetany and will cause a spasm. It's called as a carpopedal spasm because that's your carpal bones, right? Carpopedal spasm. So what happens when you inflate the BP cuff? There is going to be increased contraction of all these. They're going to go in tetany, causing this carpopedal spasm. When you see that, you indicate that your Trugeau sign is going to be positive. Okay, so quick recap, hyperparathyroidism is going to be salt and pepper sign with bones, stones, groans, moans, increased calcium and sensory, increased calcium and decreased phosphate. Whereas hypoparathyroidism is going to be decreased calcium, increased phosphate, and that's going to be your CATS. That's going to be convulsions, arrhythmia, tetany, and your stupor. Trugeau sign is when you inflate a BP cuff. It's going to cause your carpopedal spasm, which is like just your excessive tetany of your forearm muscle. Okay. Yes, carpopedal spasm is a tetany of your forearm muscle. That's why it's called as a carpopedal spasm. And you have your chopstick sign. When you tap in front of the ear, it's going to cause tingling in the distribution of the facial nerve. Everyone good? Perfect. So we finished your important glands, hyperparathyroidism. We finished your Cushing's-Addison's disease. We finished hyperthyroid. We know growth hormone problems. Now we come to a very important part, your diabetes. Always expect questions from diabetes in your exam. Always expect questions from your diabetes in your exam. Okay, so you have your type 1 diabetes mellitus and we have your type 2 diabetes mellitus. Okay, type 1, type 2. What is the difference? Let's start with the difference of your type 1, type 2 diabetes mellitus. What is the difference of type 1, type 2? Type 1 is going to be juvenile onset. Very good. Type 2 is going to be an adult onset. Okay. Type 1 is going to be like a sudden onset. Okay. It's going to be sudden onset. Could be just congenital, could be a viral infection, could be autoimmune. It's going to be very, very sudden. Type 2 is going to be a gradual onset. Type 1 is the reason. What is the reason for type 1? Type 1 is because of your deficiency of insulin. That means that it's because of the deficiency of insulin. That means that there is going to be deficiency of insulin, which means there is a problem with the beta cells of Langerhans. In your pancreas, you have your beta cells. So when there is a problem in those, it's like a destruction of the beta cells. Okay, so the destruction of the pancreatic beta cells, that is leading to your type 1. That means insulin is not getting formed. If the insulin is not getting formed, they have to be dependent on the insulin. That is why they are called as insulin dependent diabetes mellitus. Okay, insulin dependent diabetes mellitus. Whereas type 2, is there a deficiency of insulin? No, your insulin is getting produced more and more. So you can have hyperinsulinemia also. That means you have a lot of insulin. Because the body is, so basically because your blood sugar is increased, your body feels you need more insulin. So your body keeps on producing insulin. But what is happening is the adipose tissue, your tissue is not absorbing the insulin. So there is a resistance to absorption of your insulin. So insulin is not getting absorbed. There is a resistance to your absorption of your insulin, which is why it is called as insulin independent or insulin resistance. Okay, insulin resistant or insulin independent kind of diabetes mellitus. Okay, it's not dependent on the insulin. Insulin is a lot, but the tissues are not really absorbing it. Okay, so we did this. Type 1 is juvenile onset. It is sudden. It is deficiency of insulin, and it's also called as insulin dependent. Which one do you see, ketonuria or ketone bodies more? You see it in type 1 is more common to show ketonuria, ketoacidosis. Ketone bodies are more common in your type 1. And as a treatment, they are always going to need dialysis pump, or they're going to need insulin pump or dialysis or injections for your type 1. For type 2, what is the treatment? Type 2 will barely, sometimes it can have ketonuria, but it's not very common. And the treatment is going to be lifestyle modification, diet, exercises, and oral supplements as needed, or insulin as needed. But typically, it's going to be also focus on your exercise, diet, and lifestyle modification. Okay. Everyone clear? Type 1, type 2 diabetes mellitus? Very important. Okay. Now, typically when someone has diabetes mellitus, okay, what are the signs that you've learned? That whenever someone is getting diagnosed with diabetes, what are the signs that we commonly see? Very good. We see the 3 Ps. What are the 3 Ps? The polydipsia, polyphagia, polyuria. Polydipsia, excessive thirst. Polyphagia, excessive hunger. Polyuria, excessive urination. Apart from that, what do we see when we are about to diagnose a patient with diabetes? Fatigue, weight loss, right? So they say there is weight loss that will at least be like more than 10 pounds in the last 3 months. So if you see that, okay, there is weight loss which is more than 10 pounds in the last 3 months, that means it is, okay, something to worry about. Headaches, blurred vision, glycosuria. What is glycosuria? Glucose in the urine. Your kidneys are no longer able to filter it. So that's why you're going to have glucose in the urine. Polydipsia, polyphagia, polyuria. Polydipsia, excessive thirst. Polyphagia, excessive hunger. Polyuria, excessive urination. Polydipsia, polyphagia, polyuria. Fatigue, weight loss greater than 10 pounds. Blurred vision, headaches, glycosuria. These are the things if we see these symptoms in a person. I'm not yet doing the symptoms of hyperglycemia. I am just right now telling you how do you diagnose diabetes mellitus. So when we see all these symptoms, we see that the patient is complaining of weight loss. We see that the patient has fatigue, headache, blurred vision, these 3 Ps. Then you know that this patient could be having diabetes mellitus. What are the blood sugar levels? How do we consider the blood sugar levels for diabetes? You call them diabetes mellitus if the fasting blood glucose is greater than 126 mg by dl. Okay, so if the fasting blood glucose is greater than 126, if the random blood glucose, okay, if the random blood sugar is greater than 200 mg by dl, and if your HbA1c, what is HbA1c? HbA1c is a glycosylated hemoglobin. Okay, HbA1c is a glycosylated hemoglobin, and when there is, they check the blood glucose over a period of 3 months, and when that is greater than 7%, it indicates diabetes. So these are the 3 lab values that would indicate your diabetes mellitus. Your 3 Ps are going to be polydipsia, polyphagia, polyuria. Polydipsia, excessive thirst. Polyphagia, excessive hunger. Polyuria, excessive urination. Okay, so this is your diabetes mellitus, and these are going to be your levels. Okay, now everyone clear so far? What is type? So we did it in parts. What is type 1, type 2 type of diabetes mellitus? What are the common signs and symptoms that we see with diabetes mellitus? Now we did the lab values associated with diabetes mellitus. Next thing is the complications. Okay, next thing is going to be I'm sorry. So next thing is going to be your complications. Glycosuria, break down the word Betul. Always in your exam, break down the word and see. What do you see in the word? Glucose and urine. Glycosuria. So what does that mean? It means glucose in the urine, right? Glycosuria, exactly. Okay, now your complications. Now, diabetes can cause complication in any system. Always remember your complications with your diabetes could be plenty, right? A person who's diabetic can have complications everywhere. So, what all organs is it going to affect? What all system is going to affect? Let's take my musculoskeletal system. How does diabetes affect the musculoskeletal system? Yes, it can cause fatigue, it can cause your carpal tunnel syndrome, it can cause periarthritis of the shoulder, it can cause numbness, tingling, all of that. That's going to be numbness, tingling would be a part of your correct, peripheral neuropathy. But here it could be your frozen shoulder, osteoporosis, CRPS, all of this could be associated with your diabetes. Okay. Now, what about your neurosymptoms? What neurosymptoms can you see with diabetes? Diabetic neuropathy, numbness, tingling, correct, paresthesia, your loss in your balance, that is your neuro thing. Excellent. What about the cardiac? What are the cardiac symptoms? What are the cardiac complications that we can see? Yes, diabetic foot. What are the cardiac complications that we can see? Cardiac autonomic neuropathy. What is cardiac autonomic neuropathy? Remember, your heart rate becomes fixed. So they have resting tachycardia. They have a fixed heart rate. No matter what you do, the heart rate remains fixed. Okay, so that's cardiac autonomic neuropathy. In your brain, the person who's diabetic has increased chances of myocardial infarction, has increased chances of coronary artery diseases, right? Increased chances of your myocardial infarction, coronary artery disease, etc., etc. Okay, so that's called as a cardiac autonomic neuropathy. Okay, CAN. Integumentary, what complications would you see in the integumentary system? Dry skin infection, poor healing, wounds, all of that. Yes, delayed healing. Okay, that would be seen in your integumentary system. What about your kidney? Again, kidney failure. What about the eyes? You have diabetic retinopathy, right? Diabetic retinopathy, kidney failure. Then you can have liver fatty disease, anything. So, did you see like there is no organ in your body, no system in your body where diabetes cannot affect, right? Diabetes can affect anything. So, your complications could be anything when it comes to diabetes. Okay, everyone clear? Fixed heart rate more common in type 1. Jyoti, it could be both. In type 1 you could see it, and with type 2 also they can, if it affects the cardiac system, if they have cardiac autonomic neuropathy, then you can see it even with type 2. Okay. Yes. Silent ischemia. Yes, diabetic people also have silent ischemia. So everyone clear so far? Type 1, type 2, common things that we see, the complications that we see with diabetes mellitus, and your lab values. Okay. Sarah, we just did right here. Okay, these are your type 1 characteristics, and your symptoms don't change, whether it's type 1 or type 2, your symptoms don't change. We still have to do hypoglycemia. What is FIT principle for diabetes? Let's just hold on. Okay, let's just first finish the differential diagnosis. Okay, so your first thing, so now next thing that we're going to do is your signs and symptoms of hypoglycemia and your hyperglycemia. Very important. Your signs and symptoms of your hypoglycemia and your hyperglycemia. Okay, how do we remember this? Hypoglycemia, think about yourself studying for the NPTE. Okay, if you are studying for the NPTE, okay, if you are studying for the NPTE and you are not given food, let's say you're not given food and you're constantly studying for the NPT, what are you going to experience? Initially, what are you going to experience? If you're not getting food, what will happen? Excessive hunger, right? Excessive hunger, fatigue, headache, restlessness, Irritability, yes, so you feel hungry. So sweating, excessive hunger, restlessness, irritability, shakiness. Okay, you're sweating, all of that, tachycardia, all of that can be seen with your hypoglycemia as your early symptoms. So always remember that. Headache, excessive hunger, irritability, increased sweating, shakiness, tachycardia, irritability, restlessness. And just because you're not getting any food, what is your body going to do? It's going to pull up all the blood from the extremities and going to give the glucose to your brain. So if it gives all the glucose to your brain, what happens to your extremities? The extremities become cold and clammy, which is why hypoglycemia will have cold, clammy skin. Okay, so there is a mnemonic which is also called as he is tired, if you want to remember that way. Or but you could also remember it, I mean, you could remember it that way, which says headache, irritability. I mean, it doesn't, every word, every alphabet does not have a symptom, but if you want to remember headache, irritability, tachycardia, restlessness, increased sweating, okay, your excessive hunger, that is something that is going to be seen with hypoglycemia. So these were your short-term symptoms, okay, that you are studying for the NPT, you've not eaten, there is no blood glucose, you're going to get headache, you're going to get irritability, tired, tachycardia, fatigue, restlessness, dizziness, cold, clammy skin. Now think about it, 2 days gone and you've not eaten anything. If 2 days are gone and you cannot, you're not eaten anything, so you're gonna, the late signs, now you cannot focus. So you're not unable to focus, you have blurred vision, you have loss of consciousness, you start slurring. So slurred speech, and eventually, if it gets worse, you could go into a hypoglycemic coma. Okay, so hypoglycemia is when the blood glucose is less than 70. So you call it hypoglycemia when the blood glucose is less than 70. So initial signs, headache, excessive hunger, irritability, sweating, tiredness, palpitation, tachycardia, restlessness, cold, clammy skin are going to be your early signs. And your later signs are going to be fatigue, blurred vision, loss of consciousness, difficulty to concentrate, slurred speech, eventually going into a coma. Okay, hypoglycemic coma is definitely 911. But if you start seeing these signs or symptoms of hypoglycemia, you can definitely give orange juice, you can give candies, because that's going to be a treatment. Giving glucose is going to be a treatment for hypoglycemia. Yes, a person who is diabetic can see both hypoglycemia and hyperglycemia because they are on medications and the levels can fluctuate. So hypoglycemia, hyperglycemia, both can be seen in a person with diabetic. Okay. Everyone clear with the signs and symptoms of hypoglycemia? What about hyperglycemia? When your blood glucose are greater than 200, okay, when your blood glucose are greater than 200, then it will become hyperglycemia. Now, it's easy to remember hyperglycemia. Why? Because you remember your 3 Ps that we had mentioned, all the previous signs of diabetes that we had done. Same thing, you put them here. Polydipsia, polyphagia, polyuria, weight loss, fatigue, weakness, right? Fatigue, weakness, weight loss. And instead of cold, clammy skin, what do I put now? Instead of cold, clammy skin, I'm going to replace it with hot and dry skin. Okay, hot and dry skin, exactly opposite. Okay, hot and dry skin, I'm going to, yes, so that's going to be my other thing. So it's very simple to remember these signs because you already have your 3 Ps, polydipsia, polyphagia, polyuria. Okay, you have your dehydration, you're losing all the water, so you have dehydration, you have hot and dry skin, you have weight loss, you have fatigue. Additional feature, you have your Kussmaul's breathing. What is Kussmaul's breathing? Remember we did it when we did respiratory. What is Kussmaul's breathing? Kussmaul's breathing is an increase in the rate and the depth of breathing. Don't you all remember? Okay. So Kussmaul's breathing is this. It's your increase in the rate and breadth of breathing. And they can have diabetic ketoacidosis, which leads to a fruity odor breath. So if you're diagnosing diabetic ketoacidosis, what do? If diabetic ketoacidosis happens, then 911. Yes, diabetic ketoacidosis, fruity odor breath. And these people can also go into a hyperglycemic coma. If they go into a hyperglycemic coma, again, it's going to be 911. Here it was hypoglycemic coma. Here it's going to be hyperglycemic coma. Treatment of hypoglycemia is going to give glucose. Treatment of hyperglycemia is to give insulin. Right? Everyone clear with hypoglycemia, hyperglycemia? It's very simple. Hypoglycemia, think of he is tired. Okay. Hypoglycemia, you always think of he is tired. Okay. And then you know your late complications, blurred vision, coma, lack of concentration, poor concentration. And hyperglycemia, very simple: polydipsia, polyphagia, polyuria, fatigue, weight loss, dehydration, hot and dry skin. Apart from that, you just have two more things to remember: Kussmaul's breathing and the fruity odor breath, that is diabetic ketoacidosis. Okay. Yes, you can administer insulin. Everyone who's taught can administer insulin. It's just intramuscular. So I think the patients also learn how to administer insulin themselves. Okay. Anyways, but if it's a nurse is there, then of course you will tell the nurse to administer it. But if there is no one, then you can administer insulin. No, we don't continue exercises after fruit juice. Just hold on. I am going to talk of everything about exercises. We're still doing the difference. Okay. The next thing I'm going to tell you all about the exercise criteria. This was just to tell you that if a person is hypoglycemic, a fruit juice or an orange candy can help. And if the person is hyperglycemic, then the insulin is going to help. Okay. Now coming to your exercises with diabetic. Okay. This is itself a very important topic. There is one page in Goodman. I will share that with you all on the WhatsApp group later on, but I think it's also there in your LSP content images. That one page from Goodman has all the exercise considerations. Very important. We are going to be discussing each and every one of them here too, so nothing to worry. Okay, what is firstly, somebody had asked me previously, the ACSM guidelines for your diabetes mellitus. So what do you think will be your ACSM guidelines? It will be somewhere around 40 to 60 of your HRR, agreed? HRR or your VO2 max. You remember that? If you're talking in terms of heart rate, then they say 50 to 80. Okay, so they are saying 50 to. So in their textbooks and ACSM, they say 50 to 80% of your maximum heart rate. What is the RPE that they are using? The RP is somewhere around 12 to 16. Now you tell me, if the intensity is low, how many, like, should they exercise more times a week or should they exercise less time a week? Okay, 3 to 7, but typically you will be going into more frequency. You want to exercise them more times a week. Aerobic exercises, walking, treadmill, biking, etc. can be done. This is for your exercise. If they get better and you're starting resistance training with them, if you start resistance training, then how many times a week do we do that? Then you're going to give it 2 to 3 times a week. You're going to start lifting light weights, okay? Just light weights 2 to 3 times a week, okay? So that's how you're going to start with your resistance training, okay? Whenever now you're, whenever you have your exercise criteria, you always have to remember that you're never going to exercise a diabetic patient without giving them, like, without hydrating or on an empty stomach. So if they've not eaten at least 1 to 2 hours before, they have to eat. You can never exercise a diabetic patient without, like, who's not hydrated or who is not eaten recently. Okay, that is very important. Now, the next thing is, first thing, let's identify the safe range for exercise. Okay, that's your first point. Let's identify the safe range of glucose to exercise a diabetic patient. Your safe range of glucose to exercise a diabetic patient is going to be your 101 to your 249 or your 250, you can say. That's going to be your safe range to exercise a diabetic patient. Let's say your blood glucose is less than 100, but greater than 70. What do? If your blood glucose is less than 100, but you have greater than 70, then you give them a carbohydrate snack. Okay, a 15-gram carbohydrate snack. Wait for 10 to 15 minutes. Check the blood glucose again. If the blood glucose levels have come up to 100, what do? If they've come up to 100, then you are going to make them exercise. But if the blood glucose levels are below 70, just don't exercise the patient. No exercises for the patient, okay? So safe range of glucose, less than, it's going to be your 100 to 250, okay? It's going to be 100 to 250. Like they can either say 101 to 249, or sometimes they can say 100 to 250, doesn't matter. They're never going to give you one digit, okay? So 100 to 250 is your safe range. If it is greater than 70, but it is less than 100, you can give a carbohydrate snack, wait for it, and let the blood glucose to come up. But if it is less than 70, you do not exercise, okay? Now, second thing, if you have ketone bodies, do you exercise? If you have a person with ketone bodies, any blood glucose level, let's say 200 blood glucose level, but they have ketone bodies, you will never exercise. It will always be a 911 situation, okay? So this is your safe range of exercise. You do not exercise. This is your 911 situation. Now, one thing I want to ask you all, okay, a lot of times students have confusion here, is what does exercise do to the insulin sensitivity? What does the exercise do to the insulin sensitivity? Exercise increases the insulin sensitivity, right? So what does it do? Exercise increases the insulin sensitivity. That means if exercise is increasing the insulin sensitivity, means now insulin, when you exercise, insulin is getting absorbed by your tissues. Right now, when you're exercising, the insulin is getting rapidly absorbed by your tissue. So if the insulin gets absorbed by your tissue, what happens to the blood glucose? It drops, right? Your blood glucose drops. So just remember this right now. What does exercise do to the insulin sensitivity? Exercise increases the insulin sensitivity, which causes the blood glucose to drop, okay? Now so this is your second point. Now your third point is going to be, always make sure the patient is well hydrated before exercising a diabetic patient. Okay, now make sure the patient has eaten at least 2 hours before exercise. Like if it's 1 hour, I mean, ideal should be at least 1 hour. Okay, ideal should be at least 1 hour they should have eaten. But let's say they haven't, but it should never exceed beyond 2 hours. Okay, they have to eat. If they don't eat, they are going to go into hypoglycemia. Okay, so they should have at least eaten 2 hours before exercises. Ideal scenarios, 1 hour before your exercises, and they should always be well hydrated. Clear? Okay. Now, if they have diabetic neuropathy, what kind of exercises will you do? I'm going over all the exercise considerations, okay? So if they have diabetic neuropathy, what kind of exercises do? We do non-weight bearing exercises, biking exercises, etc. We're going to avoid any weight bearing exercises. Otherwise, if they don't have diabetic neuropathy, you can do weight bearing exercises. What if they have diabetic retinopathy? What if they have diabetic retinopathy? What precautions do we take if they have diabetic retinopathy? You avoid heavy resistance exercises, like heavy resistance exercises or jarred activities, because what will happen? Well, salva manure, jarred activities, heavy resistance, because it's going to increase the pressure in the eye. If it increases the pressure in the eye, it can also lead to glaucoma, right? So that can also happen. If the patient is having a diabetic cardiac autonomic neuropathy, what precaution do we take? We make sure we are not using only heart rate to prescribe exercises. We use a combination of your other things. Okay. Now, next thing, where do you put the injections? Where do we put the injection for your diabetic patient? You never put it on the exercising muscle. You always put it close to the exercising muscles, okay, which is mainly your abdomen. Why don't you put it on the exercising muscles? Why don't we put it on the exercising muscles? because it's going to get rapidly absorb the insulin. So the rapid absorption of insulin will happen, then your blood glucose is going to drop even more, causing hypoglycemia. So you always do it close to the exercising muscles, or let's say you're only exercising your lower extremities, you can do upper extremity injection. But ideally you do both, right? You do circuit training, so you can give it in the abdomen. Okay. Next thing, we know exercise increases the sensitivity to insulin. We already know that. Okay. So whenever you're giving exercise, make sure, what do we make sure whenever we're giving exercises? The timing of the medication. Excellent. Timing of the medication. What is the best time to exercise a diabetic patient? What is the best time to exercise a diabetic patient? 1 hour post meal, or also you can say 1 hour after insulin. Okay. What is the peak timing of the insulin? Insulin peak dosage is insulin peak dosage is 2 to 4 hours. You never want to exercise them when the insulin is at the peak dosage, because if the insulin is at the peak dosage and you exercise them, what will happen? They are going to go into hypoglycemia during the treatment. You don't want that. So you always exercise them 1 hour post the medication, 1 hour post the meal. Typically, they take this medication after food. So 1 hour after the meal and after the food, they can exercise. Let's say they ate their breakfast at 10 o'clock. They can exercise at 11 o'clock, but they should never exercise between 12 to 2. That is between 2 to 4 hours. You don't want to exercise because that's the peak dosage of their insulin. Clear? So that's here. This is very important. Always make sure you are well hydrated. Always make sure that your insulin is not given on the exercising muscle. It should be close to the muscle, that is your abdomen. Your exercises should preferably be in the morning to avoid the fatigue, because they get fatigued. So preferably in the morning, 1 hour after meal and your insulin medication. So far clear, everyone? It will cause hypo on the same spot, because it will cause hypo. So I can say no injection on the same spot. It will cause hypoglycemia, because if you are exercising, so let's say you are exercising the lower extremity and you give injection in the lower extremity, then that's going to cause rapid absorption of your insulin there. Okay, so inject because it will cause hyperglycemia due to scar formation. So you mean that if you keep giving it on the same spot all the time, there will be scar formation there? Yes, that can also happen. So you need to make sure that you vary. You don't just keep putting it on one spot. So you don't really want to do that. Okay, so key points, you should know your safe range, 100 to 250. Never exercise at the peak dosage of your insulin, that is 2 to 4 hours. Always exercise 1 hour after meal, 1 hour after exercise. Okay. Yes, if the patient takes insulin at 9, you can give the exercise at 10, but not between your 11 to 1 o'clock. Okay, because that's your 2 to 4 hours. So you do not give it that time. Best time to exercise is 1 hour after meal. Now, the other always stay hydrated during the treatment. Other very important part is you should have a carbohydrate snack. Okay, the patient should have a carbohydrate snack before the exercise, during the exercise, and after the exercise. Now, your carbohydrate snack doesn't have to be like every time having a heavy meal. Snack, 1 cracker, 1 banana, things like that. So it's just a 15-gram carbohydrate snack. Why do we use this carbohydrate snack before exercise, during, and after exercise? Your carbohydrate snack is needed, not protein bars. You need a carbohydrate snack. Okay, carbohydrate snack because your carbs are sustained energy, right? Carbs are long. Is sugar, like is rapid sugar, like is just taking sugar candies more sustained energy, or carbs are more sustained energy? Carbs are more sustained energy, right? Your carbs are going to be your more sustained energy, which is why before your exercise, you're taking carbs that you are basically keeping yourself that energy for throughout. It's slowly metabolizing into glucose, and slowly you're making sure that you have it throughout the exercise period. That is why for every 15 minutes of exercise, you need to have a carbohydrate snack, which is why they also say that during you should have a carbohydrate snack. And at the end of the treatment. Why do we also do it at the end of the treatment? To prevent post-exercise hypoglycemia. After the exercise is done, you still can get hypoglycemia. So you have to have a carbohydrate snack before, during, and after. Now the question here, which a lot of you all asked earlier about fruit juices and all. So if they ask you during exercise or before exercise, what should a person with diabetic take? Should they take fruit juice or should they take carbohydrate snack? Your answer will always be carbohydrate snack. Carbohydrate snack before, after, and during your exercises. That's important. Then when do you give a fruit juice? You give a fruit juice when during exercises you see that the patient has developed hypoglycemia. So during exercises, if you see that this patient has developed hypoglycemia, you're seeing those signs and symptoms: headache, irritation, tiredness, fatigue. That's when you need to give a fruit juice. Now, somebody asked, do we measure first? Yes, if you are there, always measure first rather than giving fruit juice. Always measure first, okay? But it always depends on the question, because in the question, you won't have the option of always measuring first. If there is no option and you are able to identify that these are signs and symptoms of hypoglycemia, you can give a fruit juice to that person. Depends on the option. But again, yes, so carbohydrates is given for any person who's diabetic, who's exercising before, during, after meals. It is very important to give a carbohydrate snack, but fruit juices are given during treatment if they are experiencing hypoglycemia. Okay, everyone clear so far? Why do we avoid exercising diabetic patients at night? Why do we avoid exercising diabetic patients at night? Divya, so that they have sugar, they have that sustained energy throughout their exercise, and they have, so that they don't go into hypoglycemia during the exercise. That's why you give it, because carbohydrate slowly metabolizes glucose. Okay, correct. So they can have exercise-induced hypoglycemia in their sleep if you exercise them at night. You don't want that to happen. So you never exercise a diabetic patient at night. Now, also tell me one thing. We did so much, right? We spoke about exercise considerations. We spoke about all of this. We also spoke about exercises affecting the insulin sensitivity. Now, is this true for type 2 or this is true for both type 1 and type 2 for your exercise affecting the insulin sensitivity? Okay, you said earlier, we said that type 1 is because of no production of insulin, and type 2 is because of the resistance of your glucose, resistance of the insulin into your tissues, right? So if you are exercising, it is increasing the absorption. That means it's reducing the resistance. How is it helping type 1? Does a person with type 1 have any affection of the insulin with the sensitivity of, any affection of insulin sensitivity with exercises? Not really, right? Exercises is good for type 1. You have to exercise a type 1 diabetic mellitus patient, but that does not mean, right? If you, that does not mean that you are going to experience, that does not mean that you have to, it's related to exercise sensitivity, right? So type 1, you should exercise. Exercise is very good, but your exercises has got nothing to do with the insulin sensitivity. Whereas type 2, exercise has everything to do with the insulin sensitivity, which is why we time the medication, we time the insulin, everything. With type 1, what is the best time to exercise? Always morning, early morning before breakfast. Okay, early morning before breakfast, nothing to worry about. Okay, early morning before breakfast, you don't have to worry about them not having a carbohydrate snack, nothing. Okay, early morning before breakfast, research has said that it is good for type 1. Everyone clear? Perfect. Okay. Great. So CHA snack before, during, after, fruit juice when they experience hypoglycemia. Exercise affects the insulin sensitivity only with type 2. Exercise does not affect the insulin sensitivity with type 1. Best time to exercise at type 2 and type 1, both of them is in the morning, but for type 2, it is 1 hour after meals. With type 1, does not matter, just early morning exercise is beneficial. Okay. Type 1, you can exercise without food also, it's not a problem. I think articles do say, recent like evidence-based articles say 7 a.m. early in the morning before breakfast is good for type 1 diabetes mellitus. Okay, CAN, Joanna, is a cardiac autonomic neuropathy where the heart rate remains fixed. Heart rate does not change with exercise. So if you're exercising a person with your cardiac autonomic neuropathy, then you have to make sure you use RPE, not only heart rate, as a way to monitor exercise. Okay, now one last thing. If a person is taking if a person is exercising and is taking insulin immediately after exercise, what do you do to the insulin dosage? Do you keep the same or you reduce the insulin dosage? You're going to reduce the insulin dosage by 30%. Yes, immediately, because if you, after exercise, if you give them their original insulin dosage, then the post-exercise induced hypoglycemia is going to be much more, right? Do you want post-exercise induced hypoglycemia? You don't want it. That is why your insulin dosage is going to be reduced. Everyone clear? Perfect. Great. Diabetic foot care, we already did, but tell me, what is diabetic foot care? What is, can I repeat the last one? So after you give after exercising, your insulin dosage should be reduced by around 30%, because if you keep the same dosage of insulin after exercise has already reduced the glucose. The insulin dosage, the same insulin dosage will make the person more hypoglycemic, which is why after exercise, you should reduce the insulin dosage. Okay. Yes, if they have a diabetic ulcer, then you wear a total contact cast. Remember, what kind of shoes? Snug fit shoes with laces. Okay, with laces or with Velcro. Now, because you don't want that friction to irritate your sole, right? So, I mean, you don't want that friction to cause irritation and bruises. So, you always wear well fitted shoes with lace or with Velcro. You wear white colored socks. You wash foot with warm water. You never soak your foot. You always inspect daily. You get your nails cut in that square shape by a podiatrist. Always look for white shoes with a white toe box. Alternate your shoes frequently. Okay, yes, you can use a rocker bottom sole. That's going to help with the push off. Okay, shoes with a rocker bottom kind of a sole, like a convex sole. It's going to help with push off. You can use leather shoes because they are soft. Just make sure not to use a very hard heel. Leather shoes can be used. You can buy shoes during evening time. That is correct. Okay. Now, come on, everyone tell me, what do we see with metabolic syndrome? Okay, good job. So there are, how do I remember metabolic syndrome? I remember metabolic syndrome. I typically remember metabolic syndrome as 5 things. Okay, you have to have 3 out of 5 factors. 3 out of 5 factors that are going to be positive. Okay, so what are the 3 out of 5 factors that are going to be positive? Okay, think about the main problems in the country. First problem in the country is your glucose, right? A lot of people are diabetic. We have like so much donuts due for a breakfast. So that is why diabetes is a big thing. So remember, fasting blood glucose greater than 100. That's your first point. Fasting blood glucose greater than 100, which is the other common problem. Hypertension. We have so many strokes every year. So hypertension. So blood pressure greater than 135 by 85. Remember, the values here are a little different from metabolic syndrome. You have to memorize these values. So fasting blood glucose greater than 100, blood pressure greater than 135 by 85. So your blood pressure greater than 135 by 85. Then your obesity is a big problem, correct? So obesity is your waist circumference greater than 40 in males, greater than 35 inches in female. So greater than 40 in male, greater than 35 inches in your female. What else? Your cholesterol. So your triglycerides greater than 150, and your HDL is your good cholesterol. So HDL less than 40 in males and HDL less than 50. Remember, not greater, less than, because ideally you should have greater HDL. So less than 40 in males and less than 50 in females. These are your 5 factors, okay? So metabolic syndrome is going to be cluster of these 3 out of 5 factors will be called metabolic syndrome. Fasting blood glucose greater than 100, blood pressure greater than 135 by 85, waist circumference greater than 40 in males, greater than 35 in females, triglycerides greater than 150, HDL less than 40 in males and HDL less than 50 in your females. Okay, everyone good? Metabolic syndrome. Somebody said there is a dark pigmentation at the back of the neck. That's correct. What is that dark pigmentation at the back of the neck called? So sometimes there's a dark pigment that you see in the neck of these patients who have metabolic syndrome. It looks like dirt, but it's not really dirt. It's a dark pigmentation that is because of these unhealthy factors, and that dark pigment is called as your acanthosis nigricans. Okay, acanthosis nigricans. Again, this won't be asked in your exam, but if anywhere it's there in the options, you know what it means. Okay, acanthosis nigricans is seen with your metabolic syndrome, and it is like a darkish pigment is at the back of the neck. Okay. All right. In obesity, what do we need to know the most? In obesity, what do we need to know the most? Very important is your BMI. Excellent. Okay. What is your normal BMI? What is your normal BMI? 18.5 to your 24.9. That's going to be your normal BMI. What is your overweight? 25 to 29.9. That's your overweight. Greater than 30. So grade 30 to 34.9 is going to be obese. And greater than that, okay, that's going to be your greater than 35 is going to be morbid obesity. So these are your BMI. What do you do to measure the, let's say, how do you measure the visceral fat? You can say visceral fat, or I could say, yeah, how do we measure the visceral fat? Visceral fat can be measured by the waist-hip ratio. Okay, it's something that is measured by your waist and your hip ratio. Your visceral fat is measured by a waist-hip ratio. So what should be the waist-hip ratio? Waist-hip ratio should be greater than 1 in, I mean, if the waist-hip ratio is, it should be ideal situation, it should be less than 1 in males, and it should be less than 0.8 in females. So it is nothing, it's just your waist circumference and your hip circumference. So it should be less than 1 in males and it should be less than 0.8 in females. Okay, that's your waist hip circumference. When you're exercising an obese patient, what are the things that we need to take care? If you're exercising an obese patient, again, ACSM guidelines, very important, low intensity, high frequency, 3 to 7 times a week, right? You could give like 5 to 7 times a week. Do you give the entire 30-45 minute session in one go? You don't give it in one go. You can break it down. They could be deconditioned, so you can break it down, right? It is important to break it down. Low intensity, 40 to 60, 30 to 60 minutes per day, typically 5 times a week or 5 to 7 times a week. What other things that you can add in your obese circuit training? Very good. So you're not exercising only one body part. You are mixing between upper limb, lower limb. Very good. What else? Good warm up, good cool down. Very good. Include strength, include cardio. Then pool exercises, right? Because they're so heavy. Don't you want to, like, if you give them only land exercises, it's going to cause a lot of weight on their joints, right? It's going to call a lot. It's basically you want to offload your joint. Okay, yes, offloading the joint is going to be pretty important. So yes, you are going to include strength and cardio. You're going to offload your joint. Yes, pool exercises, stretching is important. Maintaining the diet is important. Behavioral considerations are important, right? Now, other problems that obese people have is your heat intolerance, right? Obese people can also have heat intolerance, right? So yes, you don't exercise them in the hot environment. They can have hyperthermia, and also obese people can have falls risk. So therapist has to take care of themselves also. So make sure that you're using proper safety considerations so that the therapist does not get injured. And because these obese people are really like, because the skin keeps in contact with each other, they can have chaffing of the skin. So it's important to, not just exercise the same part all the time. Circuit training, aquatic exercises, stretching, everything is important. If any person comes after bariatric surgery, then the resting heart rate will be higher, less, and the treatment will be. So, Dhruvi, initially the treatment will be with comorbidities because he's just out of bariatric surgery. You cannot expect them to be at a great level. You have to start with a comorbidity treatment, and then gradually it will increase. Heart rate has nothing to do with their bariatric surgery, but if they are on any kind of medication, then you will see the heart rate issue. Okay. The RPE for your obese people. What is the RPE for obese people? What is the approximate RPE that you could give for these people? 13 to 16. I feel it's like 13 to 16 is the ratio. It may change from patient to patient, but 13 to 16 would be your approximate RPE. Okay, 40 to 60% of your VO2 max, 40 to 60% of your heart rate reserve. All right. Everyone clear about obesity? Great. Now, the next one that we're going to do some kidney considerations and we're going to do incontinence, okay? Renal problems. What are the typical renal problems that we see? What are the typical renal problems that we see? First, most common one. Excellent, UTI. You could have your lower UTI, you could have your upper UTI, right? Lower urinary tract infection, upper urinary tract infection. What does a lower urinary tract infection indicate? Your UTI could be either lower or it could be upper. So what does the lower one indicate? What are the structures that are involved in the lower UTI? Very good. It's going to be your bladder. It's going to be your urethra, right? Your bladder and your urethra. What about the upper UTI? The kidney and the ureter. So your kidney, the upper part. So your kidney and the ureter is going to be your upper UTI. Your bladder and the urethra is going to be your lower UTI. What do we see? What are the signs and symptoms that we see with the lower UTI? Come on, you all know. Cloudy urine, frequency, yes, urgency, frequency, cloudy urine, foul smelling, okay, like you're painful in the groin region, lower abdominal, yes, sometimes blood and urine, that's correct. So burning sensation, urgency, cloudy urine, increased frequency, foul smelling urine, pain in the groin region, and sometimes blood in the urine. That's your lower UTI. What about upper UTI? What about upper UTI? They will also have frequency urgency, but they will have the flank pain. What is the sign that is positive? Your Murphy's test is going to be positive for your upper UTI because it's your, what is upper UTI? Upper UTI is your kidney infection. Kidney infection is also called as pyelonephritis. Okay, pyelonephritis is characterized by a very pungent smelling urine. So if you are diagnosing that the patient has a very pungent smelling urine, okay, very pungent smelling urine, fever, malaise, a lot of body weakness, fever, okay, then you can, and Murphy's sign positive, it is an indication of a kidney infection. It's going to be 911. Okay, so UTI could be lower and upper. Lower is definitely less dangerous. Upper is very dangerous. It's actual infection of your kidney, and that could lead to serious problems, which is why 911. Lower is, we keep getting it all the time. So it's just urgency, frequency, pain, sometimes blood in the urine, foul smelling, cloudy colored, cloudy urine. Okay, clear about the different types of UTI. UTI typically is more common in females than in males because of the short urethra. Okay, and can be seen with diabetes, old age, pregnancy. UTIs are very, very common. Okay, what are the other problems that we see in kidney? Kidney stones, very good. You see renal calculi. What is characteristic of renal calculi? Flank pain. Okay, it's again your flank pain. Okay, whenever they have kidney stones, they are going to experience your flank pain. Okay, there's going to be pain, like it's going to be stone anywhere in the urinary system. So they're going to have a lot of pain in that side of the quadrant, the lower abdomen, that side of the quadrant, in the bladder area. So there's going to be a lot of pain in that region. Okay, they're going to have a severe flank pain radiating from the back all the way to the groin region. That is what you will see in your renal. It's just basically crystallization of the urine. Okay, it's basically crystallization because of your calcium oxalate. So when there is a crystallization of the urine substances because of the deposition of calcium oxalate, it can lead to renal stones. And renal stones are mainly going to be your painful in the abdomen, painful in that side of the quadrant, perineal area, bladder area, etc. So sign flank pain radiating all the way to the groin. So as a treatment, what do they do for kidney stones? What do they do as a treatment of the kidney stones? Diuretics, fluid intake, drink a lot of water, diuretics, avoid food that have a lot of calcium oxalate, like spinach, tomatoes. Spinach, tomatoes should be avoided, right? And if they do, like, I think there's something which is called as extracorporeal shockwave therapy. So that extracorporeal shockwave therapy that breaks down the stones. So that is also something that is done in case of renal calculi. Okay. Then, most important, your renal failure. What is renal failure? Renal failure is when your kidney is failing. Okay, when your kidney is failing, it is going to be typically called as renal failure. Yes, the kidney is unable to do its job. Okay, the kidney is unable to do its job. So renal failure can either be acute or renal failure can be chronic. So you can have an acute renal failure or you can have a chronic renal failure. Why would you have an acute renal failure? Sudden problem, right? Anything sudden. So sudden obstruction, sudden infection. So anything that is happening in the kidney, like suddenly, like maybe a bacterial infection of the kidney or sudden obstruction or a trauma that can lead to an acute renal failure. But is chronic sudden? No, chronic is building up from a long period of time. So conditions like a person is having long stage diabetes or a person is having long time hypertension, right? Or a person is already having a chronic renal disease. So all that can lead to a chronic renal failure. Okay, all this can lead to a chronic renal failure. So what do we see with chronic renal failure then? What gets accumulated? A lot of it's basically, it's not able to filter out things. So what is increased? The urea. The urea is basically, that is increased. They have uremia. So that's like the urea is not getting filtered out, right? So they have that. Then yes, so hypertension. Yes, they have a hypertension. You do see hypertension. Now we call it like ESRD, where we see that there is an end stage. ESRD is called as an end stage renal disease. Okay. Now, what happens in ESRD to the blood pressure? Definitely hypertension. We have a lot of books that say elevated blood pressure, elevated creatine level. That is excellent. Yes, they have elevated serum creatine level and they have elevated blood pressure. But your diastolic blood pressure does decrease. That's correct. Your diastolic blood pressure is going to decrease. There have been researches and articles that say that your diastolic blood pressure decreases with an end-stage renal disease, but otherwise you do have hypertension. Okay, what do we do if a person is having renal failure? What is the only treatment? ESRD is end-stage renal dysfunction. Okay, ESRD, end stage renal dysfunction. It's your last stage where you have a lot of uremia, where a lot of toxic products are there. Kidney is unable to do its job. There is hypertension, there is decreased diastolic pressure. That is what happens in your ESRD. Only treatment you have is your dialysis to remove the toxic substances. Okay, what are the precautions that we take with dialysis? When we're doing dialysis, what are the precautions that we take? Firstly, you never ever measure blood pressure on the area of the shunt, because when you do dialysis, you have to do like a shunt, right? You can do your peritoneal shunt, right? So it when like they do like a they do put a peritoneal catheter. So you have to make sure that you never are going to take blood pressure on the same arm as the shunt. Very important. What else? Wherever the catheter is there, make sure there is no trauma to that catheter. Okay, so never take blood pressure on the same side. Never have trauma around the area of the catheter. Okay, and what else about exercises and dialysis? The previous day somebody had posted this question on the group. So when do you exercise with dialysis? You are preferably advised to exercise on non-dialysis days, and you can exercise dialysis before. I mean, you can exercise before and during dialysis. That is also okay. So during, before, and preferably on non-dialysis days. But you never exercise after dialysis, because after dialysis, the patient is extremely tired, drained, and everything. They will not be able to exercise. So before, during, and on the non-dialysis days. Clear? Side effects of dialysis. What are the long-term side effects of dialysis? Long-term side effects. Long-term side effects are going to be your dialysis dementia. Are you all with me? Come on, no sleeping. We have to help each other. Dialysis dementia and dialysis disequilibrium. What do we understand by dialysis dementia? Dialysis dementia, what do we understand by dialysis dementia? Dialysis dementia means a person who's on long-term dialysis for a very long time. So if the patient is on dialysis for a very long time, what happens? The patient starts getting dementia, loss of memory, difficulty concentration, and dialysis disequilibrium is they start having nausea, vomiting, headache, balance problem, unable to balance them, instability. That is why disequilibrium and dementia. If you're on dialysis, if you're on chronic dialysis for a very long period, you can develop dialysis dementia and dialysis disequilibrium. It doesn't cause instability. No, Joanna, if you're exercising before dialysis, patient is fine. So it's not going to cause before dialysis, okay? Yes, I can repeat. So dialysis, whenever a person is on dialysis, never take blood pressure on the same arm, never cause trauma around the catheter. Always exercise on non-dialysis days, preferably. You can exercise on days that are before and during dialysis, but never after dialysis. And if the patient is on dialysis for a long time, you can have side effects like the dialysis dementia. Break down the word. What is dementia? Loss of memory. So when they have confusion, loss of memory, poor concentration, that is called as dialysis dementia. And dialysis equilibrium is, again, they feel nauseous, vomiting, seizures, and they feel unstable and instability. That is your dialysis disequilibrium. Okay, everyone clear now? Okay. Now let's do your incontinence. Very important. You do get questions on incontinence all the time. Okay. I think there is like I have I think a paragraph on incontinence, like treatment of incontinence. I will share that after class on the WhatsApp group. But incontinence is pretty simple, so don't complicate it for yourself. A lot of times I see we just try and make things complicated for ourselves. Okay, all right. Everyone awake? Come on, 15, 20 minutes more and then we'll be done. Okay, it's the first type of incontinence. Stress incontinence. Why do we have stress incontinence? What is the reason for stress incontinence? Very good. Stress incontinence is the leakage of the urine because of the increase in the abdominal pressure. So whenever there is leakage of the urine because of an increase in the pressure, that is stress incontinence. Now, you could have stress incontinence during pregnancy due to the weakness of the pelvic floor muscles, correct? You could have it during pregnancy, when a person is exercising, okay? When a person is coughing, sneezing, okay, so weakness of the pelvic floor muscle is a cause of stress incontinence. You can see it during pregnancy, exercising, exerting, coughing, sneezing. If they give you a question where they tell you the patient is lifting heavy boxes from point A to point B, what is the type of incontinence that we see? It's going to be stress incontinence. Why? Because they're exercising. Okay, so laughing, sneezing, coughing, exercising, pregnancy, you typically will see your stress incontinence. Okay, so what is stress incontinence? Stress incontinence is because it's a leakage of the urine. It is because of the weakness of the pelvic floor muscles. It can be seen during pregnancy, exercises, coughing, sneezing, laughing, etc. And what would be the treatment of the stress incontinence? Your strengthening of the pelvic floor muscles, okay? Your strengthening of the pelvic floor muscles. You could either use, how would you strengthen the pelvic floor muscles? You could use your Kegels exercises and you could use your vaginal cone exercises. So your Kegels and your vaginal cone exercises. What are vaginal cones exercises? That a cone is placed inside your vagina and you are expected to contract it, right? You're expected to contract it. So Kegels and your vaginal cone exercises are going to be very beneficial. Now, other thing that you can give is EMG biofeedback. Okay, you can give biofeedback. Now, books do mention that first we'll always give Kegels exercises and all for a couple of weeks, 2 to 3 weeks before we start with your biofeedback. Now, with biofeedback, what do you want to do? You want to do the strengthening. So if you want to do the strengthening, you use the strengthening parameters. That means your electrodes are going to be far placed, and what is going to be your sensitivity? Sensitivity is going to be high. Okay, so this is your stress incontinence. So you know the cause of it, you know the conditions, what you can see, and when can you see stress incontinence, and we know the treatment for your stress incontinence, right? Now the next thing is going to be your urge incontinence. Okay, urge incontinence is something that is because it's an extreme urge to void. Now your bladder goes on contracting, so it's an extreme urge to void. You feel the sensation like your bladder is contracting, you feel the sensation, but you're not really able to delay it. You're not able to delay it, and there is going to be like an incontinence. Now, one thing that I'm going to tell you here, if I say urge incontinence, don't tell me that my bladder is going to be spastic all the time. It's not necessary that my bladder is spastic. Yes, my bladder can be contracting a lot more. That doesn't mean my bladder is spastic. Yes, spastic bladder also leads to urge incontinence. I'm not saying no. Spinal cord injury will have spastic bladder that will cause urge incontinence. But is all the urge incontinence spinal cord injury? Do we mix their treatment? No, it's not. You can have urge incontinence with a lot of other reasons apart from your neuro things. Also, having just an infection can cause urge incontinence, right? Having infection can cause urge incontinence. Spastic bladder, neurogenic bladder can also cause urge incontinence, right? Neurogenic bladders are something related to neuro. So your neurogenic bladders can either be spastic, they can either be flaccid, okay? So urge is not like, yes, spastic bladders will have urge incontinence, but it's not necessary that your urge is only spastic. Your urge incontinence is just an extreme urge to void because your bladder is contracting a lot and you cannot delay the urge to void. What are the conditions that you may see this? You may see when there is an infection. Whenever there is an infection, you will see, or whenever there is a spastic bladder, like in stroke or in spinal cord injury, okay, or hypersensitive bladder. That is when reflexive, overacting, hypersensitive bladder. Now, what is overactive? The detrusor muscle. So what is overactive here? It's going to be your detrusor muscle. What is the detrusor muscle? The detrusor muscle is the muscle of the bladder. So the bladder muscle is so overactive, it is so spastic, it's so hypersensitive that it goes on contracting and there is always an urge to void. So stroke, infection, spinal cord injury, Parkinson's disorder. Parkinson's disorder will also see urge incontinence. The rigidity, the Parkinson's disorder will also see urge incontinence. Now, your multiple sclerosis varies, okay, because multiple sclerosis can affect anything. Multiple sclerosis can also have a urge incontinence. Multiple sclerosis can also have your overflow incontinence. There are different things about it. You can either have urge incontinence or they can also have your overflow incontinence. Okay. So in your exam, I don't see questions related to multiple sclerosis because of the discrepancies. Yes, if you have an option of mix, just choose mix, but otherwise we can pick urge. Okay, urge, and if urge is not then the option, we can pick overflow. But typically they will not just tell you that, tell me the incontinence with multiple sclerosis. No, they will give you some signs and symptoms because multiple sclerosis has discrepancies. You can have either as spastic, you can also have overflow. That is why they will not only ask you the incontinence for multiple sclerosis. Okay, so that's your urge incontinence. So typically they see when you do one particular action, the urge increases. So let's say if I'm trying to focus, if I'm trying to focus, if I'm trying to put the key in the hole, okay, if I'm going to do one action like putting the key in the hole, and I have that excessive urge to void and I void out. That is urge incontinence, right? Like when I'm focused on a typical thing, trying to do something, and I can have the urge incontinence. All right. Now, what is the treatment for urge incontinence? You do give biofeedback for spasticity parameters, right? You give for spasticity because you want to now relax. Where do you give the biofeedback? Do you still give it on the pelvic floor muscles? No, it's not the pelvic floor muscles now. What is the muscle? It is the detrusor muscle. So biofeedback can be given over the detrusor muscle if it becomes too difficult to reach the detrusor muscle. So they also give it on the sphincter region, like your sphincter region. So what will be, how will your electrodes placed now? Your electrodes will be closely placed, and what will be the sensitivity? Sensitivity is going to be low because now you're trying to relax something. So any infection, stroke, spinal cord injury, Parkinson's, that's going to have your urge incontinence. Treatment for urge incontinence, definitely your biofeedback. You could also do a timed voiding program. Okay, so that means they are basically trying to void out at regular intervals. Okay, so that means they're not leaking out very frequently. So timed voiding program. Can I generalize and say suprapubic tapping and my suprapubic tapping is something that can be done for urge incontinence? No, it's only for SCI. Okay, always remember all this catheterization and all this, it's for SCI, it's not for urge incontinence. Okay, we did that in SCI, you have your bladder sphincter dyssynergia, which is why you do all these things. Okay, urge incontinence, your treatment is always going to be treat the infection. Okay, if needed, biofeedback can be given, time voiding program can be taught. That's going to be your treatment for your urge incontinence. Yes, prostatitis is going to be urge incontinence. That's correct, Joanna. Okay. Then your next incontinence is your overflow incontinence. Again, overflow does not mean spinal cord injury only, does not mean Valsalva and Kreitzman, you are my treatment for overflow. No. But yes, spinal cord injury, flaccid bladder can see overflow incontinence. But overflow does not mean everything related to spinal cord injury. Okay. So remember, same thing. So what is overflow incontinence? Overflow incontinence has a dribbling of the urine. Why does it have dribbling of the urine? So keyword in overflow. What is the keyword in overflow incontinence? The keyword is a dribbling. Okay. With keyword fit, urge incontinence is going to be excessive contraction or excessive urge to void. Okay. So urge to void, hyperreflexive, that is urge incontinence. Overflow is going to be dribbling of urine because of a over-distended bladder. So bladder that is over-distended, over-expanded, there is dribbling of urine, the bladder which does not have reflexes. If you have a neuro problem, then it's going to be a flaccid bladder without any reflexes or without basically inactive reflexes, right? So that's going to be your overflow incontinence. All right. Now, which condition do we always have overflow incontinence? What did we discuss? Diabetes mellitus, very good. Benign prostatic hyperplasia, always if overflow is an option, pick overflow for benign prostatic hyperplasia. So your diabetes mellitus, benign prostatic hyperplasia, flaccid bladder, multiple sclerosis can have overflow incontinence. What would be the treatment of overflow incontinence? What did we do yesterday? Not prompted voiding. Prompted voiding is different. This is called as double voiding. See that urge has timed voiding. Overflow is double voiding. What is double voiding? After they are done voiding, okay, after they are done voiding, you are going to make sure that they force and they void again, because you are going to prevent the dribbling of the urine. So that is your double voiding. Okay. And overflow, so stress, urge, overflow, and your functional incontinence. What do we see with functional incontinence? Functional means that there is a problem with the mind-body connection. Okay, that means there is a disrupted mind-body connection. That means you don't have a problem, anything related to your urination. The problem is maybe you have Alzheimer's, dementia. Maybe you are unable to reach the bathroom, maybe because of a lot of obstacles on the way, or because of your cognitive problems, because of environmental barriers, because of your strength deficits. You are unable, because of your gait problems, you are unable to reach the bathroom. Because you are unable to reach the bathroom, it is going to be called as functional incontinence. So typically patients with dementia, patients with dementia, patients with stroke, or sometimes patients with you could say late stages of Parkinson's disease, right? Late stages of Parkinson's disease. Okay. SCI can, depending if they are not on catheter, then you can say SCI, but typically SCI patients, if there is a problem, they will be on catheter most of the times. Okay. So whatever the reason is, if they cannot reach the bathroom, if the problem is only in reaching the bathroom because of a mind or a body connection, that's going to be your functional incontinence. So your behavioral training or assistive device to overcome barriers, those are going to be your treatment. If you get a question that says that incontinence that can be improved by strengthening of the lower extremity musculature, what would you answer? What would be the incontinence that would improve after strengthening of the lower extremity musculature or after gait training? That will be your functional incontinence, right? Because if you strengthen your lower extremity musculature or you're doing gait training, you are able to, that means that's the problem, which is why they were not able to reach the bathroom. So they are able to do that. So for functional incontinence, you always remove the clutter. Remove the clutter means make the environment clear so that they can reach the bathroom. And second thing is going to be prompted voiding. What is the prompted voiding meaning? Prompted voiding means keep prompting. You can do, you need to go to the bathroom. Keep prompting that it's the time to go to the bathroom. So giving prompts is functional. Timing their voiding schedule, that okay, this is the time you drink water, this is the time you go to the bathroom, that is timed voiding. And double voiding is you're voiding 2 times. Okay, so timed voiding with urge, double voiding with overflow, prompted voiding with functional. Okay, everyone clear with all the types of incontinence? And then you have mixed. Mixed is usually stress and urge together. You have to work on both. Prompting is you constantly prompt them. Okay, you prompt them, go to, like, going to the bathroom, prompting, because sometimes when they have a problem with Alzheimer's, I mean, there's not a problem with the urination. The problem is they don't remember that they have to urinate. So you have to prompt them to urinate. Yes, reminding. Timing is making a schedule for them. Okay, Betul, timing is to make a schedule for them. Okay, that this is the time, this is how much water you drink. This is when you go to the bathroom. That's your timing. Prompted is you tell them it's time to go to the bathroom. You tell them to go to the bathroom because they don't remember going to the bathroom. Okay, and catheterization, you give a catheter to overflow incontinence only when the bladder is completely flaccid and you don't have any control. But for BPH, let's say benign prostatic hyperplasia or diabetes mellitus, you don't go ahead and keep giving catheter to everyone, right? Only if the bladder is flaccid, then you are going to go ahead and give a catheter. If the patient says he cannot hold the urine and wants to avoid ambulating in the community due to this problem, is it urge incontinence? Wants to avoid? Yes, if he cannot hold the urine, then yes, that's going to be urge. If there is an excessive urge, then yes, whatever, like if he cannot hold the urine, if there is an excessive urge, then yes, it's going to be a urge incontinence. Yes, that's correct, Dhruvi. You can do anything. You can give any prompts. You can give visual prompts. You can give auditory prompts. You can put post-its. Anything is going to be considered as your prompted voiding. Okay. Urethra blockage is overflow. Yes, it's because of your enlargement of the prostate gland. You will have an overflow incontinence. Again, Sarah, same question. I just answered to that. We give catheter in overflow. I just told you if your bladder is flaccid, you can give the catheter in overflow. If you have overflow incontinence just with a person with diabetes or anything, you just don't want to give catheter. If it's completely flaccid, like a spinal cord injury, you can give catheterization. Okay. All right. Now, in your other, so these were your main things in your other systems. Okay, most important. Other side things that we need to know. Let's say if we talk about the hematological system. Okay, I'm just going to give you like key points. Yes, we're going to talk a little bit about system interactions, or we're going to talk about few key points here. So first thing is any hematological disorder. Again, any hematological disorder can be system interaction because it affects all your joints and everything. So if you have a hematological disorder, what can it be? Correct? It can be anemia, right? It can be anemia. Anemia is your less, it's basically reduction in your hemoglobin, reduction in production of your RBCs. So if you have like very severe anemia, you cannot give exercises with very severe anemia, right? What is the hemoglobin below which you cannot give exercises? Correct. You cannot give exercises below 8. You do not want to give exercises. Now, the other type of anemia, there is one anemia which is called as a sickle cell anemia. Okay. So what do we see with sickle cell anemia? The RBC is now sickle shape. Sickle means like a bean shape, okay, like a sickle. Usually RBCs are cylindrical, so they nicely go into the arteries. But if it's like a crescent shape or like a bean shape kind of an RBC, what will happen? Will it be able to go smoothly? Will it be able to go smoothly in the arteries? No, it is basically causing the blockage of the arteries. So if it's causing a blockage, what is it causing? It's going to cause abdominal pain. It's going to cause visceral pain. It is your anemia. You're going to have weakness. So as a PT, what are the important considerations we should take care when we are treating a patient with sickle cell anemia? Low to moderate exercise, very good. Proper hydration. Water is very, very important. Hydration. Low to moderate exercise and no cryotherapy. Why no cryotherapy? Because cryotherapy causes vasoconstriction, and with sickle cell, your arteries are already constricted. So no cold with sickle cell anemia, low to moderate exercise is preferred, and proper hydration preferred. Okay, that's your sickle cell anemia. The other condition that we have is your hemophilia. The other condition that we have is your hemophilia. So what is happening in hemophilia? Hemophilia is basically lack of the clotting factor. So your blood is not clotting. So what are the things that you can see? If the blood doesn't clot, when you bruise, your blood is not clotting, you're going to have hemorrhages. You can have hemorrhage into the muscle, you can have hemorrhage into your joint, you can have hemarthrosis, bleeding into the muscles, bleeding into the joints. All of that can be seen with your hemophilia. Yes, everything is going to be reduced. Your INR is going to be reduced, your prothrombin time, your thromboplastin time, all of that is going to be reduced with your hemophilia. Your blood is not clotting. Okay. So what, as a PT, what are our important consideration? Should we give aspirin for pain? Should we give aspirin for pain as a PT? Never, because aspirin is also going to make the blood more thinner. So no aspirin for pain. Should we give heat? No heat. Should we give cryotherapy? Yes, you can give cryotherapy, okay? So no cryotherapy for sickle cell anemia, but you can give hot therapy in sickle cell anemia. And for hemophilia, you can give hot therapy. I mean, you cannot give hot therapy, but you can give cryotherapy. Think about it. Hemophilia is more blood flowing, so you want to constrict, so you can give cold. And sickle is already constricted, you want it to flow, so you are going to give hot. So in your acute stages, if you have hemophilia in your acute stage of hemophilia, what do we do? acute stage of hemophilia, we do the RICE, rest, ice, compression, elevation, always. Splinting of joints, protection of joint. If a patient has acute hemophilia, we are always going to do non-weight bearing and we are going to do RICE. Once the patient is in subacute, you start with simple exercises, isometric exercises, aquatic exercises, open chain exercises. So isometric, aquatic, open chain, that can be done in your subacute. Will you do closed chain exercises? No. Why you don't do closed chain exercises? Because that can increase the that can cause into hemarthrosis. It can increase the bleeding into the joint, and then when it becomes chronic, you can give light aerobic exercises, aerobic fitness, strength training a little bit, that you can do it during chronic. So remember, hemophilia is a bleeding disorder. Blood does not clot. Okay, so you can give cryotherapy, no giving heat, no giving weight bearing exercises. Acute phase, just give rice and protection. Subacute, you can do open chain, aquatic and isometric exercise. And last, that's your chronic phases, where you can start doing actual aerobic exercises, light aerobic exercises. Okay, good, everyone. What comes under system interaction? Mainly your hematological systems will come. Your cancer will come under system interactions. Yes, your myositis hypertrophic ossificans can happen as a sequel of hemorrhage into the muscle. Cancer, pregnancy, rheumatoid arthritis. Most of these autoimmune conditions that we study, do autoimmune only affect one body part? No, autoimmune affect everything. That is why all these autoimmune conditions, they become a part of your system interaction. I think Dr. Singh takes a class on system interactions. There you can see it will be cancer, it will be pregnancy. And the table out there is a table which is in your reading material that talks about the proper level of WBC, your appropriate level of platelets, your appropriate level of hemoglobin. That table is gold. You have to know that table. Do it from your slides. Okay, do it from your slides. There are discrepancies in Goodman's, okay, additions. So do it from your final frontier slides. Okay, contractures seen in hemophilia, it can be seen later on if you got, like, let's say a hemorrhage, or you got ischemia or anything that could lead to contractures later on, or not otherwise. Okay, Jyoti. Cancer, what do you need to know? First thing, yes, your staging of cancer. You should know what is stage 1, stage 2, stage 3, stage 4 cancer. What are the common signs? Yes, your TMN staging. What are the common signs of cancer? What will tell you that, okay, this person is a red flag for cancer? Night pain, good. Fatigue, night pain, what else? Weight loss, then abnormal bowel and bladder, hoarseness of voice, feeling of lump in the throat, abnormal bleeding, right? All these are your red flags for cancer. If it's a skin, then we know the ABCDE melanoma. So it's very important to know your red flags for cancer, because in the question, if you see that, you have to immediately refer the patient immediately refer the patient out to the physician. Okay. If your platelets are less than 10,000, do you do resistive exercises, or can you measure MMT? You cannot. Good. Okay. If the patient has undergone a mastectomy, what do you do on day 1? What's your first thing to do on day 1 if the patient has undergone a mastectomy? Upper extremity range of motion. Very good. Otherwise, it's going to lead to stiffness and it's going to lead to more lymphedema. Okay. What are the side effects of chemotherapy? Vomiting, nausea, fatigue, ulcers, peptic ulcers, everything GI related. Perfect. Okay, everything GI related is going to be mainly your side effects of chemotherapy. What about radiotherapy? What are the side effects of radiotherapy? Nerve problem, tingling, burns, hair loss, skin thickening. So yes, all your neuro and all your skin related. That's going to be your side effects of your radiotherapy. All the GI related, appetite related is going to be chemotherapy. Know your side effects of chemoradiotherapy can be asked on the exam. Okay, so for cancer, know the stages, know that table, know your red flags for cancer. Okay, of course, your ACSM is going to stay the same, 11 to 13, low intensity exercises, more frequency, break down the exercise, that all stays the same for your cancer. Okay, everyone clear? Like I told you for the other systems, PPE and your for your personal protective equipment, I'll remind me if I forget. You can always message me to put that slide in the to put the old class into your cohort. So if you want, you can have a quick review. And for notes for that, I will share on the WhatsApp group. It's already there on your LSP content folder, but I can just share them again. Okay. So yes, we are officially done with other systems. Congratulations. I'm going to stop the recording here.